pain. It's something every single one of us has experienced at some point, right? But have you ever wondered what's actually going on in your body when you feel pain?
It's an important question, Yenna. Pain, as defined by the International Association for the Study of Pain, is much more than just a physical sensation. They describe it as an unpleasant sensory and emotional experience linked to actual or potential tissue damage.
Yeah, exactly. And that emotional side of pain, it's what makes it so variable, so personal. No two people feel pain in exactly the same way.
Absolutely. Even the type of pain you experience can vary significantly. For example, there's nociceptive pain, which is caused by damage to body tissues. Now, that can be broken into somatic pain from tissues like bones or muscles, and visceral pain, which stems from organs like the small intestine or, say, the pancreas.
Oh, pancreatitis. That's a big one in our field. Visceral pain like that can be very intense and often, poorly localized. Patients might describe it as a deep, squeezing discomfort. But what about neuropathic pain?
That's another category altogether. Neuropathic pain comes from nerves themselves being damaged or dysfunctional. It's often described as burning, shooting, or even numb. And shingles, for instance, is a classic real-world example of this.
Shingles. Now there's an unpleasant one. It tends to creep up along nerve paths, right? Like a fiery, jabbing sensation.
That's right. And these types of pain require very different approaches to management, which brings us to the World Health Organization's pain ladder, something every healthcare provider should be familiar with.
Yes, the WHO pain ladder. I love this framework because it's so practical. It starts at step 1 with non-opioid medications like paracetamol or NSAIDs, which are great for mild pain. Then it moves up through steps 2 and 3, adding in stronger opioids as the pain gets more severe.
And the approach encourages combining medications to target pain from multiple angles while minimizing side effects. It's a brilliant way to tailor treatment to the individual's needs.
Right. And the beauty of it is that it's dynamic. It changes as the patient's pain changes. Honestly, understanding this hierarchy is game-changing for managing pain effectively in clinical settings.
No doubt about it. And that distinction between nociceptive and neuropathic pain we discussed earlier plays a big role in deciding which medications you might use. But more on that in a moment.
Ethan, you mentioned medication choices a moment ago, so let's pick up from there. When we talk about managing pain, analgesics are at the center of it all, aren't they? But it's not just about popping a pill. These drugs act in very specific ways.
Absolutely. And one of the most important groups to understand is opioids. These are potent painkillers, often used for moderate to severe pain. They work on specific receptors in your body called mu receptors.
Right. The mu receptors. These are like the gatekeepers, aren't they? When opioids like morphine or fentanyl bind to them, they essentially dial down the pain signals being sent to your brain.
That's a great way to think about it. They reduce the excitability of neurons by affecting potassium and calcium ion channels. The result? Your nerve cells become less responsive to pain signals.
Which is brilliant for pain relief, but also makes opioids a double-edged sword. I mean, these drugs come with significant risks.
They do. Respiratory depression, sedation, and even dependence if not carefully managed. And this is why opioids need to be prescribed and monitored very closely.
And then we have NSAIDs, non-steroidal anti-inflammatory drugs. These are the go-to for mild to moderate pain, right? Thanks to their anti-inflammatory properties and broader accessibility.
Exactly. But they're not without their challenges. Drugs like ibuprofen or aspirin work by blocking enzymes called cyclooxygenase 1 and 2, COX-1 and COX-2. This inhibits the production of prostaglandins, which are responsible for inflammation and pain.
Ah, prostaglandins, the classic culprits. But while NSAIDs do an excellent job of reducing inflammation, their effects on COX enzymes can also have a downside.
That's right. Blocking COX-1, for instance, affects the stomach's protective lining, increasing the risk for things like gastric ulcers and gastrointestinal bleeding.
And don't forget their impact on the kidneys. NSAIDs can impair renal function, especially in patients with pre-existing conditions or who are dehydrated.
Exactly, which is why careful prescribing and monitoring are so important with these medications. Now, paracetamol is another popular option. Unlike NSAIDs, it doesn't have anti-inflammatory effects, but it's fantastic for pain relief and fever reduction.
But here's the catch. Paracetamol overdose. It's safe within recommended doses, but if that dose is exceeded, it's hepatotoxic. Liver cells just break down under the pressure.
That's why N-acetylcysteine can be life-saving. It replenishes glutathione levels in the liver, which helps neutralize the toxic byproducts of paracetamol metabolism before they cause irreparable damage.
Such a critical intervention. Speaking of which, naloxone, an absolute game changer when it comes to opioid overdoses.
Definitely. Naloxone works by blocking opioid receptors. It reverses the effects like respiratory depression and loss of consciousness almost instantly. It's a true lifesaver in emergency settings.
It absolutely is. And it highlights just how important it is to act quickly in those situations. Timing is everything. Now that we've gone over the mechanisms and risks of these medications, let's turn our focus to application. In nursing, managing pain isn't just about knowing which drug to use. It's about anticipating the risks and crafting a care plan that's tailored to the unique needs of the patient right in front of you.
Exactly. And when it comes to pain management, certain medications require a watchful eye. Opioids, for instance. Respiratory depression is one of the most serious risks, and nurses must monitor respiratory rate, depth and oxygen saturation regularly. If it drops below safe levels, intervention can be life-saving.
Absolutely. Let's not forget about assessing the Glasgow Coma Score, especially when opioids are administered intravenously. Too fast and, well, we've seen how quickly things can take a turn. But monitoring doesn't stop with opioids. What about NSAIDs, Ethan?
NSAIDs, like ibuprofen, can be deceptively tricky, can't they? While they're so readily available, they come with their own dangers, renal impairment being a big one. And for those with pre-existing kidney issues, even standard doses can lead to complications.
Exactly. And add gastrointestinal risks into the mix. Ulcers, bleeding. Things you'd never expect from your seemingly innocent over-the-counter painkiller. It makes careful patient assessment absolutely critical.
That actually reminds me of a case, probably worth sharing with our listeners, a patient we had who came in with severe post-operative pain. He was already on NSAIDs, but had underlying kidney disease. His pain was through the roof, but because of his renal impairment, the NSAIDs were doing more harm than good.
Oh, I know exactly where you're going with this. This is such a great example of tailoring treatment plans. What did you end up doing?
Well, after reassessment, looking at his full history and current meds, we opted for a carefully titrated opioid regimen combined with non-pharmacological strategies like guided breathing exercises for pain distraction. Within days, his pain levels dropped and his kidney function stabilized.
See, that's the beauty of individualized care. Patients aren't textbook examples. They're people with unique needs and responses to treatments. And this is where holistic assessment plays such an important role, doesn't it?
It does. Holistic assessments mean listening, observing, and following up. Pain isn't just physical, it's emotional and psychological too. Patients' feedback on what's working or not working is invaluable when adapting care plans.
Exactly. And I think what's worth emphasizing here is that as nurses, we're not just the ones administering drugs. We're educators, advocates, and problem solvers. Our job is to take the pharmacological frameworks we're taught and make them apply to real lives, the lives of our patients who are counting on us.
Well said, Yenna. And with the complexity of pain management, it's about ongoing education, collaboration with the wider healthcare team, and always putting patient safety first.
It really is. At the end of the day, every choice we make impacts someone's quality of life. And honestly, there's no greater privilege than that responsibility.
And on that note, it's been a great conversation. It's always rewarding diving into such vital topics, especially for clinicians out there eager to make a difference.
Couldn't agree more, Ethan. Thanks for joining us, and a big thank you to everyone listening. Go out there, keep learning, and most importantly, stay compassionate in your practice. We'll see you next time.